your health. I want to thank you for joining us today in the studio, and for those of you watching us on Facebook, it's good to be back from vacation. I really enjoyed my time off. Joining us today is Dr. Joel Turner, and let me explain to you, Dr. Turner wears many hats at GBMC. He's the Vice Chairman of the Department of Surgery. He's the Chief of Minimally Invasive Surgery and a member of the Thyroid Center at GBMC, and he's here today because we are going to talk about the thyroid. It's that little thing in your body, but it really controls a lot, right? I mean, it controls your heart, your kidneys, your skin, and if you believe it or not, approximately 20 million people in the U.S. suffer from some type of thyroid disorder. Luckily, though, some of those disorders, the solution is surgery. So to talk about surgical options for our thyroid is Dr. Joel Turner. Dr. Turner, welcome and thank you for coming today.
Thanks, John.
So let's start about the thyroid. I mean, I gave a really poor man's explanation of what it is and what it does, but maybe you can give us a little bit more.
Sure. I guess the easiest thing to describe it is it's basically your thermostat. So when your thyroid's functioning normally, you're normal. Most people that show up with thyroid nodules have a normal functioning thyroid. When it functions too fast or hyperthyroid, your heart races, you may have a tremor, you may have loose stools, you may have an active appetite and lose weight, which sounds good, but it's not. And then the exact opposite for things when it's functioning low or hypothyroid. But most people walking around have normal thyroid function.
And we're going to talk about hypo and hyperthyroidism a little bit later on in our show. Let me ask you, though, this question is, what are some of the main causes of thyroid disorders among people?
So when you, like I said, most people that have thyroid nodules, their thyroid functions just fine. And I get that question all the time. I don't understand, I have thyroid nodules, but it functions fine. They're two separate things. So when you talk about function, the most common sort of hyperfunctioning, or why does it hyperfunction? You get things like Graves' disease, which I'm sure people have heard of, which was autoimmune, which means your body causes it. You may have bulging eyes, you may have other symptoms for the hyperthyroidism. And that's basically when your whole gland is functioning too fast. Sometimes there's multiple nodules that cause you to be hyperthyroid, and sometimes you may have one nodule that's hyperfunctioning with the rest of the thyroid being normal. And those are the main reasons for you to be hyper or to have too much thyroid function. And when you talk about hypo or low thyroid function, most of the time, one common cause is surgery. We've taken it out, or taken part of it out, or two, you have something called like Hashimoto's thyroiditis, which is very common as well. That is a sort of an inflammation that happens in your thyroid, and it essentially burns out where it doesn't make enough thyroid hormone.
So let's go back to this. So we talk about hyperthyroidism and hypothyroidism. So really quick, give us some idea or a synopsis of what are some of the symptoms, causes, how's it diagnosed, and some of the treatment options.
Sure. So it's not uncommon. Again, as a surgeon, I'll see markedly less people that come in for complaining of the symptoms because they've seen their primary doctor, and their primary doctor diagnoses them with hyper or hypo, and then they usually will see an endocrinologist, or the primary doctor will start to treat them for one or the other. But usually when you think of it as your thermostat being set too high, you'll have heat intolerance, you may notice your heart racing, you may realize that you have tons of energy, but over time that actually may decrease. And these things can be non-specific, which means that lots of people may feel they have palpitations or they may be losing weight. Most people aren't going to have hyperthyroidism. So it's always good if you have even an inkling, which is people will just go see their primary doctor. And it's very common for people, very common complaint to say, oh, I'm gaining weight, I must be my thyroid, and it must be not working normally, and most of the time you'll go and the thyroid will be functioning just fine. So usually, and we've had tons of questions. The last time we had a little Facebook outing where people wanted to know, I'm heavy, is my thyroid? It could be. It's all a possibility, and that way, really the best thing is if there's any concern by the patient, just simply go in and check with your regular medical doctor. It's a simple blood test, and they'll be able to tell whether or not your thyroid's functioning normally.
Joining us today is Dr. Joel Turner, Chief of Minimally Invasive Surgery at GBMC and also a member of the Thyroid Center at Greater Baltimore Medical Center. If you have any questions, I encourage you, those at home or here in the studio, to pass them along to one of our members. But those at home watching us on Facebook, please feel free to add your questions in the comment section, or if for privacy concerns, if you would like, you can also private message us as well. Dr. Turner, you talked about hypo and hyperthyroidism, and you mentioned the word surgery. So here's my question. When and why should someone consider thyroid surgery, also known as a thyroidectomy, correct?
Sure. So when we talk about thyroid surgery, the good thing is no one really ever wants surgery for things. So most things with thyroid disease is managed non-operatively. Obviously, if you have low thyroid, you get put on replacement. When we talk about hyperthyroid, there's choices between medicine and radioactive iodine and surgery. There's also cancer for why we do surgery, and there's also sometimes people develop compressive symptoms. The thyroid sits in your neck, kind of where my tie is, and sometimes people will develop sort of a pressure sensation and or have difficulty swallowing, and all those are indications for surgery.
Dr. Joel Turner from GBMC joining us today here on To Your Health. Dr. Turner, how should someone be evaluated for surgery, and what's the evaluation process for a surgical candidate?
Sure. So unlike other things where we might have patients come directly to us to say like, oh, I have a hernia, where you'll look down and you might see a hernia where the patient diagnosed it. They may or may not have checked with their regular medical doctor. Usually for thyroid problems, they'll almost always have gone to their internist or they'll get referred to an endocrinologist who, again, depending on what's going on, they'll be worked up with an ultrasound, possibly a thyroid scan, possibly a biopsy, which is a fine needle aspiration, which sounds worse than it is, very well tolerated. And only then, usually they'll be sent in. And sometimes when we see people in the office that have had an ultrasound for a recently detected thyroid nodule, we'll order the ultrasound and the biopsy and then determine which way to go.
Okay. We have a question from Sandra, and she wants to know what type of diagnostic tests are appropriate in diagnosing thyroid conditions and what symptoms are indicative of potential thyroid conditions.
Sure. So that's Sandra, good question. Again, most people that come in with thyroid nodules usually are asymptomatic. Occasionally, they can have a pressure sensation or difficulty swallowing, but most people, it's either found by themselves or a family member, or it's seen on imaging. They may have shoulder pain or neck pain, and we incidentally find a thyroid nodule. But again, the baseline studies are usually going to be an ultrasound, which again is non-invasive, no radiation, historically proven to be a very good mode for evaluating the thyroid and following up as well after the initial imaging. But if Sandra has specific concerns or she has thyroid nodules, really it's best to have your medical doctor sort of get you in a pipeline and get seen by an endocrinologist.
Joining us today, Dr. Joel Turner from the Greater Baltimore Medical Center's Thyroid Center and also the Chief of Minimally Invasive Surgery at GBMC. I encourage you all watching us at home and members of our studio, if you have any questions, to please submit them. We greatly appreciate it. We do have actually a question. Jessica.
Yes, doctor. Are there any correlations between particular ethnicities or age groups or genders with respect to thyroid problems? And with respect to cancer, is cancer more common among people now with the thyroid because we just know more about it, much like what has happened with prostate cancer? Prostate cancer wasn't diagnosed as much in the past because people didn't live long enough to realize they had the problem. So what's the situation with the thyroid in that respect, please?
Sure. So really good question. So we do see areas, which is not to sound alarming, but there are areas in the country that do have a higher incidence of malignant disease for thyroid. But remember, without causing hysteria, most of the thyroid nodules are benign that we find. So it's really, people say if you're a woman and you get health care, we'll find a breast lump. If you're a man, you live long enough, we'll find a prostate nodule. If you're a person and you get health care, we will find a thyroid nodule. So it's not anything to get alarmed about. I think that, again, there's studies to show that although the incidence may be increasing for thyroid cancer, it's most likely the fact that our imaging is better and we pick up more. So although the incidence is going up, it's probably because we're seeing more and even changing the sort of how we describe things. So now we even have micro papillary cancer as an example, which is just to say it's something so small that previously, decades ago, we may not have even seen it, and now we're finding these things. So it's going up, but likely as a result of us being better with our imaging.
We're rocking and rolling now, Dr. Turner. We have 2 more questions from our audience members. Jessica?
Should thyroid testing be done routinely, annually?
Sure. Good question. Again, part of that not going to necessarily fall to me as an endocrine surgeon, but usually the internist, if you're being seen by an endocrinologist, they're going to check your thyroid function studies. Some of it's insurance based as to what they'll cover, so that's really a question to ask your doctor. But usually, if there are any concerns, they'll add it to the panel, specifically to address the concern.
I have a question for you. Is there any preoperative testing that a patient needs to go through before they have their surgery?
Sure, good question. So when we talk about thyroid surgery, again, besides the workup that they'll have done specifically related to your thyroid, usually, at least at GBMC, we follow a sort of a best practice guidelines from our anesthesia department. So if you're healthy, you may not need any preoperative studies or labs. Depending on whether or not you have high blood pressure or high cholesterol or diabetes or overweight, you may have other preoperative studies, EKGs, chest x-rays, but that's based on any other medical problems that you have, nothing specific for the thyroid.
Jessica?
We have one more. If a biopsy reports inconclusive, what is the next step?
Sure. Panic at all times. No. So when we look at biopsies, there's basically 4 categories, and this is a generalization. There's normal, cancer, we didn't get enough cells, and then it falls into this indeterminate. So the person's endocrinologist would be able to talk to them about whether or not they would repeat it in several months, or whether or not they would be a candidate for genetic testing for the nodule, or based on the size of the nodule, sometimes they're just sent for surgery based on that biopsy. So there's no clear-cut answer. It really depends on the specifics, and that's something the endocrinologist would manage.
Joining us today is Dr. Joel Turner, Chairman of Minimally Invasive Surgery at GBMC and also member of the Thyroid Center. Dr. Turner, if somebody wants to come in and have an appointment with you, what's the best way to do that?
Sure. I always recommend the old school, just pick up the telephone. Probably no one has a landline anymore, but no, telephone works. Our extension at GBMC is 4800, so that's 443-849. 4800 is the main office number.
All right, let's focus now on surgery here. I was doing some research, and from what I discovered, just broadly, there's 2 types of thyroid surgery. There is partial or a total thyroidectomy. Can you give us a quick definition of each one? And also, are they both outpatient procedures, or can you explain on that?
Sure. So if you think about the thyroid as being sort of a puffy H, and usually it's about 2 inches or so high, but again, can vary based on the patient and the size of the nodules or the size of the gland, but normal gland is around 2 inches or so. A hemithyroid is usually half of the thyroid taken out. We do offer that as, I'll say, an outpatient procedure, but we usually watch you a little bit longer for around a total of 6 hours after the surgery. And if a person wants to go home, we let them go home. Total thyroids are taking out the whole entire thyroid, and those people stay overnight, and we usually send you home the next morning.
Are there any risks with having thyroid surgery, or what are some of the possible side effects of having a thyroidectomy?
No, completely risk-free. It's the only surgery known, has no risk whatsoever. No, all of the risks, the 4 main risks for thyroid surgery are usually less than 1%. So I tell my patients over 99% of the time, nothing bad will happen, which is good. We like a low-risk surgery. But when you talk about any surgery, the first 2 risks are bleeding and infection. Again, very unusual. There are a main set of nerves that come right underneath your thyroid, and they control the muscles that move your vocal cords. there can be some bruising and some swelling around those nerves, and that can give you a hoarse voice. The risk is permanent hoarseness from a permanent injury. And there are also some small glands that control your calcium level around the thyroid. We don't try to take them out. The risk is that they're unintentionally injured or removed, and you'd have permanently low calcium, or in this case, you'd have to take calcium and vitamin D. So those are the four main risks, and like I said, around 99% of the time or higher, they don't occur.
We have actually a Facebook question. We have two of them. One comes from Tanya, and I think we kind of addressed this one early on, but let's do it again. She says, I'm overweight, and I had one doctor prescribe medication only. At what point would I be a surgical candidate?
So again, it's a really broad. Most people that are overweight are not going to have hypothyroidism. So it's hard to answer that question. But if you have any concerns, you may not be feeling your normal self plus the weight gain. It's really best to contact your doctor and have them, order the labs and see if there's anything that may not be functioning normally. And that's what I would tell you broadly. This is not, people come in and say, I think it's a lipoma or a cyst on their arm. This is not something you're going to be able to sort of Google or Wikipedia and get an answer, because a lot of these symptoms are nonspecific. So you're just not going to be able to put it together, or at least very accurately. Most people you're just going to have to go see your doctor and see what the labs show.
Again, joining us today here on To Your Health is Dr. Joel Turner, Chief of Minimally Invasive Surgery at GBMC and member of the Thyroid Center. We have another question from a viewer. Her name is Lisa. And Lisa asks, after surgery, do you still have to take a supplement and still have blood tests?
Sure. So good question, Lisa. So I tell my patients, again, when you have half of your thyroid out, we usually don't start you on anything. You might get pain medicine to go home with. When you have your whole thyroid out, it's been my practice and most people's practice to give you calcium replacement for 2 weeks, which is calcium and a vitamin D, along with starting you on thyroid hormone. And your endocrinologist will usually want to check your thyroid function studies sometime within the first month or two, which is a blood level that she was asking about after your surgery.
So you have the surgery. Let's talk after the surgical procedure is done. What is the recovery period following thyroid surgery?
So good question. I tell my patients you plan on missing a week of work, although you'll be doing things from home within the first couple of days. Most people don't take a narcotic. If you do take a narcotic, it's usually for a day or so, usually some Motrin or Tylenol. We always put an ice pack on right after surgery, which seems to help a lot. And usually you're driving in a week or less. Most people drive themselves back to the appointment the next week. And even from the gym or swimming, as soon as the next stiffness goes away, I always tell people your activity is as tolerated. If you feel great in 4 or 5 days and want to go for a bike ride or a run, you can do it. There's no specific limitations.
We got about 5 more minutes left. We do have a question from one of our viewers. Jessica?
Is there a greater occurrence for thyroid disease in any particular group, such as obese people, different genders, location, or other medical issues?
Sure. Nothing that we would have as far as screening goes. So we wouldn't find people to say, oh, you're 42, you need to have a thyroid ultrasound, or oh, you're obese, we can't examine your neck, so we need to get an ultrasound. I think I had mentioned before, there's definitely geographic regions where we see hotspots for cancer. And what was the other? There was a question of.
It was just other medical issues.
Oh, so not enough where we would say, like when we have colonoscopy or mammography, where you reach a certain age or you're a certain type of patient, you need screening for your thyroid. So it's not to that level. We do see people that have family members that have thyroid problems. And again, those are specific situations where because of their family members, they may need screening.
Actually, there's a two-part question. What are some of the complications following thyroid surgery, and will a patient need to take or start any medication after the surgery?
Right. So I think that sort of alluded to this before, that when you have your whole thyroid out, you absolutely need to start thyroid hormone replacement. And when we talk about the complications, those were the main 4 risk factors that we talk about: the bleeding, infection, the hoarseness, and the low calcium. And all of those, again, less than 1% chance.
We have a question from one of our audience members.
I'm wondering, is it worth it to pay the extra money to get the regular Synthroid medication versus the generic? That's one of my questions.
So great question, and I know that Dr. Horowitz is on next that may be able to shed more light on that, but I will tell you what I've been told, which is usually the unrelated to the price, but usually the brand names tend to have a little bit a tighter control in terms of the actual dose than the generics. But she'll be able to shed more light on that in the next session.
We got about 2 more minutes left. What's that phone number again in case somebody wants to come in and
Sure.
make an appointment?
The office number is 443-849-4800.
One of the questions that came up was, can you eat after surgery? And are there any physical
Never. You cannot eat for weeks.
Oh.
No. I tell people, we give people liquids after surgery just from the anesthesia standpoint. But in general, again, they go home with no restrictions. So if you have a bad sore throat, you might have softer food. If not any specific restrictions from that standpoint.
You mentioned the R word, restrictions. What about physical activity, physical restrictions?
Usually for the first day, people don't feel like doing too much, but in general, they recover pretty quickly. And I wanted to also mention, John, the American Thyroid Association has really good website, very patient-friendly, really answers a lot of great questions that people tend to have. It's a very good website to go to.
Thank you. Fair enough. And one of our viewers asked a question: what's the best advice you give to your patients when they're being released from the hospital after their thyroid, or whether it's a total or partial thyroid, has been removed? And what is the most important week 1 and 2 after thyroid removal?
Sure. I just tell people to just let their own discomfort guide you, that you're going to have a little bit of neck stiffness, a little bit of a sore throat, and your activity and your diet, you're just guided by your own discomfort. And usually within the first 3 to 5 days, you're back to a lot of your normal activities.
We got about a minute left and one more question.
Is it possible for thyroid levels to change after a couple of years post-thyroidectomy? And if so, is it possible for medication levels to change to compensate for that?
Yes. I'm sure that, again, the endocrinologist or your internist is usually going to follow you, and you usually get your thyroid function studies, which are lab tests. If you have a total thyroid, done more frequently early on, and then less frequently once you're on a stable dose, but it's not ever never. So your doctor will always check it on the off chance, especially if you're not feeling well, to see whether or not your requirements have changed.
Joining us today, Dr. Joel Turner here on To Your Health, Chief of Minimally Invasive Surgery at GBMC and member of the Thyroid Center. If you don't believe it, time's up. That's all we have for today. We appreciate you coming out. I also want to appreciate everybody here for joining us in the studio, and for those, thank you. Oh, no, those are for him, not for me, but thank you. Fear not, though, the conversation about the thyroid does continue on Greater Living Live with 2 awesome hosts, Mary Beth Marsden back there and Don Scott. Hey, guys, welcome back. Hope you guys enjoyed your vacation. Dr. Turner, again, I want to thank you for being here today and for all the great information that you've provided to us. I hope you enjoyed it as well. Join us here next month on To Your Health as we go from the top part of our body to the lower half. We're going to talk about ankle injuries and ankle surgery here on To Your Health on Wednesday, August 8th at 12:30. Until then, I wish you all to your health. Cheers.